Hello, and welcome to today's webinar, The Right Tools to Drive Value-Based Care. Before we get started, I'd like to announce a few brief housekeeping details. Today's session is being recorded, and an online archive of today's event will be available a few days after the call. You will receive an email from AHIP that will ask if you would like to receive the archive. Please respond to the email if you would. I'd like to remind you of AHIP's antitrust statement and ask that you reference it in the Handouts tab on the left side of your screen. The antitrust statement prohibits us from discussing competitively sensitive information. Please keep in mind that you may ask a question at any time during the presentation by typing your question into the chat box located in the lower left-hand corner of your screen and then click Send. You may adjust the size of the slides to fit your screen by clicking on the Scale button located in the upper right-hand side of your screen. We're very fortunate to have with us today Dr. Mark Crockett. Dr. Crockett is a pioneer in the healthcare industry's accountable care movement with extensive knowledge in the fields of emergency medicine, medical informatics, and systems architecture. Prior to taking the leadership role at RiseHealth, Mark was Chief Medical Officer at OptumInsight's Accountable Care Solutions. His systems technology expertise helped drive product development at companies such as Ibex Healthdata Systems, where he was CEO and later President of Emergency Care for Picis. Dr. Crockett earned his MD at the University of Illinois College of Medicine after graduating Wheaton College. He practices emergency medicine at Advocate Good Samaritan Hospital in Downers Grove, Illinois, and is published author and a fellow of the American College of Emergency Physicians. At this time, I would like to turn the floor over to Dr. Crockett.
Well, thank you very much. I appreciate the kind introduction. I'm going to go through a number of things today, bringing together a little bit of information about how we see things in accountable care right now. RISE has been doing work with both providers and payers in accountable care type arrangements now for several years. And so we're going to talk a little bit about population health for payers and providers in combination. And then population health in action, and really just talk about a practical approach to getting things done around patient care and accountable arrangements and how to make these things really practically successful. This is not going to be a lot of theory today. It's really a lot about how to get stuff done. And just talk about kind of some of the hot button industry issues for payers in terms of how to get this done. So just to talk a little bit about this, I don't have to go into a lot of detail around medical costs and why it's such a significant problem. But I think everybody here on the phone would agree that it's become highly visible that the United States, we pay a lot of money for health care, and we don't necessarily get some of the outcomes that you see in other countries. What I think is really ignored in a lot of that conversation is the fact that consumer behavior has a lot to do with why that occurs. And so, if you look at just medical adherence, adherence to medications, those costs add up to more than $100 billion annually in avoidable healthcare spending. That 69% of total costs are influenced by consumer behavior. And so getting to a point where we get better quality and lower costs in healthcare to a really significant extent, we need patients to choose differently. We need to ask them to participate in different types of behaviors. And through my, I'm an emergency medicine physician, so I tend to see that very closely. But I've also worked in the payer environment, and so understanding all of the different players, trying to get a better to a better place in terms of behavior. There are things that are practical, and the relationships that we need to use to get to a point where we change some of these behaviors. And I think that that the accountable care movement really gives us some real advantages in terms of being in alignment with our patients, And so a lot of what we talk about today is going to be about how to get patients to do something differently and really participate in their care and get engaged. These types of accountable care contracts are really starting to get some traction. So, right now, this is a source of the 2013 Accountable Payment Survey. Right now, there's about 35% of providers that have a total cost of care contract in place, and about 65% of the providers don't have one in place. In 2017, we're estimating that about 75% of total providers are going to have a total cost of care contract in place. And I think that it's really got tremendous momentum. A lot of the payers have these contracts available to providers. A lot of providers are starting to take those contracts. They really mean a tremendous partnership between payer and provider to get to the patient and to get that patient to do something differently. But not in any of this is how successful are those going to be, and if they're not successful and we don't see improvements in terms of this, how are we going to wind up? What will be the next step in this in the process? And none of it looks particularly good. So everybody, I think, who is involved in this is extremely vested in making these successful. I practice at Advocate Healthcare in Chicago. Advocate has had significant success in these types of arrangements over time. We certainly learned some lessons there, and I think that our organization, RiseHealth, has learned additional lessons, and we'll talk a little bit about how that works. As we look at organizations that are providers and payers that are trying to combine together, starting from a fee-for-service organization and get to more of an accountable care kind of contract, there's a lot of variability in how people are trying to do this. It's really significantly challenging. And particularly if a provider has some of their patients in fee-for-service and some of their patients in a accountable care contract, the incentives can actually go against each other in daily operations. And those types of conflicts can really make it difficult for people to get behind an accountable care contract or a total cost of care contract. What we've seen is that providers particularly don't want to look at a patient's insurance base sheet and say, okay, this patient belongs to an Aetna or a Cigna or a United or this particular total cost of care contract, so I will do something different than I would with straight Medicare. The physicians don't really want to do that. So a lot of response has been, you know what, I will wait to participate in these contracts until there's an overwhelming number of them, and then I will try to rapidly climb the level of competence necessary to do it. That's not something that, and so they wind up just not participating. Other organizations are building large clinically integrated networks on the basis that they have faith that their own clinical transformation will get to a point where there will be significant value in it without proving a return on investment in either the provider or the payer world. Those types of organizations, some of them are successful, some of them are not. So we see organizations all over the map in terms of their road, how far they are along. We see them all over the place in terms of where they are in terms of their success. And so, how do we get cleanly from one place to another is something that people need a real roadmap to be able to get to. And I think that, our organization has been successful around doing this. And I think that, one of the key aspects of that is that, respecting the power of the relationship. This is third-party research that just talks about how patients get their care. How do they engage and who do they listen to in terms of the process of getting their care? Who can convince a patient to take their medications, to stop smoking, to lose weight, etc. That really their family is the most powerful actor in that. But right behind that is their physician. And some of the organizations that have been trying to be powerful around the total cost of care, things like disease management organizations and payers that have their own disease management organizations built within them or are contracting for that, they fall really far down in terms of the relationship. And so, it's our fundamental belief that organizations that are payers that are linking arms with providers, either through contractual arrangements or other types of arrangements where they're in partnership, are taking advantage of this very powerful physician relationship with the patient to drive behavior. And that's been something that we've seen as being successful. And there's a real roadmap where it can be successful for both the payer and the provider and the patient, which is really the magic of the type of accountable care contract that we're all trying to make successful. What's interesting around this is, as we start to look at the historical, patients have seen some reluctance to engage with their health plan in managing their care for a variety of different reasons. It becomes a difficult situation to manage a relationship with them. Calling the patient at home to try to sort of nag the patient to take their medications or lose weight is a difficult business to scale. It's hard to get that organization. And again, that relationship isn't there. And a lot of the information that type of disease management is used is dated. So if you're trying to use a fully adjudicated claim stream in order to do care management, we had one of our patients talk to us recently about the fact that they had a call from their disease manager at one of the plans 9 months after they had been diagnosed with a very significant infection. And they had just had their last antibiotic treatment and their PICC line and everything else taken out when they finally had the plan call them and talk to them about disease management. Under those kinds of circumstances, it's just a question of is it in any way effective? And so, getting to better, cleaner, faster data and getting to a point where the relationship is one is something that the health plans have struggled with being able to do. Payers are also, though, in a situation where they have unique data sets, they have the ability to drive patients in terms of referrals. There's some really big advantages to being a payer. And so when it comes to being able to combine with a provider, the payer provides some really significant advantages when they're in partnership. They have the ability to set achievable goals. They have the ability to help providers leverage data that they have to manage their attributed populations. And they can shift patient care management from the plan to the provider effectively and contract for it. And so we've seen this kind of thing and seen it work. And I think what we want to talk about is a payer model that gets to population health in combination with the provider. Right now, I'm an emergency medicine physician, and so again, I talk about the fact that the road to where I see patients, it's paved by failures in care coordination. And frankly, the incentives are all wrong. Patients come in because they, were discharged from the hospital, didn't understand their medications, never got to their follow-up, wind up presenting back to me a very short period of time later with what was obviously a preventable readmission, just as one example. And technology has been, particularly with meaningful use in some of the electronic medical records, this has been, considered a burden to providers. As an EMR vendor for a number of years, I was asking the providers, hey, if you just spend, 3 more minutes with me, we can do electronic prescribing, and we can reduce some errors for the patients. But it's additional burden to the provider with not necessarily a clear ROI for them or for the patients. And so, this is sort of the state of the union right now. Population health, is an additional burden. So a lot of the ways in which it's traditionally been done, where you produce a registry and then you say to your doctor, hey doctor, these are patients that I want you to pay attention to, that it just becomes one more patient they have to look out for. It becomes a very difficult situation for them to concentrate on that in addition to all the other technology needs and everything else. But involving the provider in a coordinated care strategy can be very effective in either fee-for-service or value models. And if payers are willing to turn their data loose into the provider organization, if they're willing to work in a coordinated way for the provider, they really can achieve a triple aim with better patient satisfaction, better care, and more efficient care and lower cost. We've seen it work. But this concept of population health that's being, talked about as, the payer put some dollars in and provide some analytics which are not necessarily actionable because it's on old data, and then you try to get the physicians to do something different. It's not necessarily a really effective model. However, having the ability to target care to patients, to change a care plan at the time when it's actionable in the doctor's office, that's something that is a totally different animal. So we've talked about population health. I think there are probably 4,000 population health companies in this country right now. Most of them analytics vendors that have unique insights. Some of them very good and very important companies. They're doing a lot of good work. But at the point where you actually have to manage a patient differently and get them to engage in their care differently, I think maybe there's a better way to talk about it, which is basically targeted care. Targeted care gets to a point where a patient is actually taken care of differently and participating differently. So number one, working on population health, talking to your providers, partnering with your providers to get to a point where you're able to work in combination, setting measurable and achievable provider targets, understanding that STARS rating, HEDIS measures, ED utilization, readmissions, pain medication prescriptions, that these kinds of metrics are all things that are going to, are really important, having the data to support them, setting those in the contract, but then providing the actionable data. Provider data is interesting. I was an EMR vendor for a lot of time. We had a lot of data on the episode of care for patients that we would see. The thing is that a goodly number of the patients that we would see were also seeing providers that were outside of our network. So I knew exactly what was going on when they were in our system, but I didn't know what they were doing when they got seen by a healthcare provider elsewhere. And I live in Chicago, and I would say that anybody who has even reasonable mental facilities goes somewhere else for the winter. I think this winter particularly, everybody would agree with that. So there were whole aspects of the patient's care that we wouldn't have access to if they travel, if they get care in another hospital, etc. The payer data has that information. So the payer data is broader. I can see all the different inpatient facilities. I can see all kinds of prescription fills and refills. So there's a payer data component that adds to the provider data and really completes it. That said, the payer data is relatively old. The provider data gives me a critical insight into data that's going on right now. So in the crossover between what's going on in provider data and payer data is what we consider to be actionable patient data. It gives me both the context necessary to know what should be going on with this patient in terms of the plan, but also it's actionable enough so that I know that this patient was seen in the emergency department with back pain, is now asking for an eligibility check in a surgeon's office. And I can tell you right off the bat, algorithmically, what is about to happen. And so being able to get to a point where you have a data infrastructure that's able to get to that important crossover of data is something that it really requires a partnership between payer and provider to get to. And frankly, in the past, payers have felt that provider data is very difficult to get to. It's very difficult to examine, hard to aggregate. Providers have felt the same way about payer data, that it's difficult to get a hold of and it's not necessarily timely. So there are more and more organizations that are able to grab this data, bring it into a single warehouse, and provide a more timely, actionable type of view that will let you get to a point where you can have the provider addressing the patient and getting to the point where, in a real-time way, they can do the right thing for the patient. In terms of the physicians, they have to be able to see, actionable insights into physician performance that are credible. Telling the physician, look, the patient hasn't had a flu shot. The physician knows that the patient had a flu shot because they were, a part of a targeted program at work. Having the kind of, giving people performance, physician performance, it has to be credible, and it has to be able to be contributed to by the provider. And then the ability to identify gaps in care, health plan, medical management, being able to get this in front of the provider at the right time when there is a ability to get something different done, for example, in the office, and then measuring and tracking clinical program outcomes and improve patient satisfaction. These are sort of the important aspects of this. And what I would say is that what we've seen is that if the information is not timely, or if it's an additional burden on the physician in the office, then you're simply not going to get the physician action on a patient. What we've also seen, however, is that the physician office staff and team-based care organizations can be enormously effective around this. The physician is not the only place that you need that you have as a possible option in terms of getting to better care, and we'll get to that in a minute. And then tracking correct diagnosis, coding, and risk stratification. Every patient needs to have a plan, particularly the high cost and high risk patients. And so getting to a point where that plan is driven off the data and has the largest amount of aggregated sources so that you can get to correct diagnosis, coding, and risk stratification. This is something that's an important piece of this. Supporting providers managing multiple payer relationships with a single platform. A number of different payers have brought to market tools in a real attempt to help. And that's wonderful, and that's great work, and those organizations are doing really important things. However, from the provider's perspective, having 3 or 4 different portals and 3 or 4 different claim systems in order to be able to get to the clinical action, it makes it very difficult inside the provider's workflow to be able to address, to be able to be efficient. And if you start cutting down efficiency, particularly when a significant portion of those patients are still on a fee-for-service model, you're directly negatively impacting the bottom line. And being sensitive to that, I think, is really important. And then, what we see is that, a payer model that allows the payer to offer high-impact tools to support patients that are medical initiatives, if it's a multiple payer tool, if it's the ability to provide support, and crucially, it supports both fee-for-service and accountable care, that's likely to be the most successful. So focusing on tools for delivery that do both is really important. What we know to be true about population health is that, and what we're have started to call targeted care, that providers can thrive in the preparation for new models of care and reimbursement. That it is not a situation where providers looking at these new accountable care contracts that the same kind of preparation necessary to be successful there will help them in their fee-for-service work. So, moving to team-based care where they have additional support from extenders, that they have additional support from telephone services and technology, that these are the things that help with both models. And I think that that's really important as we go forward. Exceptional technology is out there right now to help distribute physician work, improve the patient in care, and drive improved quality and practice revenues. And I think that all the payers on the phone today would agree that paying additional dollars to a particular primary care practice is fine if you're paying less to a number of specialists that used to be doing a lot of expensive and potentially not necessarily evidence-based procedures. And then patients who experience coordinated and accessible care have increased patient satisfaction, and that drives them to a higher level of engagement in their care. And then, the primary care physician that does this type of care for their patients has additional credibility when it comes time to make important decisions about the kind of care that they're going to pursue. In the emergency department, I can tell you that, if you're a primary care physician and a patient calls on a Tuesday at 3 o'clock in the afternoon and says, I have a terrible sore throat, and they're given an appointment, a week away, I can guarantee you that's an emergency department visit. These types of, those types of services necessary to support access for patients, it just directly derives care and derives a better cost outcome, but it also drives that coordination, that accessible care drives significant patient satisfaction, which is better for the practice. Interestingly, that's one of the things that we really saw as a powerful piece of the models that we've been participating in. In a typical morning session for a provider, they might see 16 patients. The physician might see 16 patients, and most of that's in the electronic medical record. That those visits are acutely sick patients and maintenance of patients that are sick. But we all tend to focus on those visits as the entire way to drive care and drive engagement with the care process. There's also, for a lot of these organizations now, outbound care management calls. So selecting a certain group of patients to do outbound care management, that is also going on during that period of time. But what we found was that in that practice, there's about 64 inbound calls, about 4 to 1 inbound calls for every patient visit you see. And those calls in the typical physician office are completely ignored. So you wind up with, or not completely ignored, but the opportunities are ignored. So you get a patient who comes in and who's calling and says, I want 3 months of my Avandia for my diabetes. And the typical workflow now would be to have that handled by an MA or a nurse who would ask some questions. When was the last time we saw you? Do you have any other significant medical illnesses or anything else? Having that then go to back to a physician to call in the prescription, and they might have 6 or 10 of these things to do during the morning session, and that's pretty much it. And I think that the payers on the phone right now would agree that if that was a patient where you already know as a payer that this person hasn't had a flu shot, hasn't had a whole colonoscopy, that the patient is on currently 10 medications, of which 6 of them are known to that physician in the first place. And that the person has seen, 2 emergency department visits between primary care visits. If that is known, that patient is a care coordination failure. It's a high-risk patient that is likely to create, both emergency department visits. If that information was available to the person handling the phone call, instead of generating a 3-month prescription for Avandia, what it would generate is, hey, we'd like to give you 2 weeks worth of your Avandia, and let's get you in here, and let's get get you in here for a care coordination and a visit discussion about polypharmacy. And what we found is that type of almost concierge-like approach to the inbound phone calls. For those of you who've worked with call centers before, these people who are calling patients at home, they have about maybe a 30% connect rate and maybe a 10% resolution on the phone call rate. The inbound phone calls, they're calling you and they're connecting with you 100% of the time. And the psychology of trying to take one of these people and convert them onto your discussion as opposed to create a new discussion with them means that these patients, they're already activated, they already have your number, they're ready to talk to you about their care. And so what we find is that this model of engaging patients in the provider's office when they're ready to engage over either a telephone services or a technology reach out kind of a model outside of the physician visit itself can be an important way to impact and target the care for a group of people who are involved with the practice, who can be directed by the practice, and you can do that without so much physician change management in a team-based care environment. And because it's such an efficient way to practice, it can drive physician revenue as well. And so you wind up with a winning patient experience. You wind up with a winning patient, winning patient outcomes, and you wind up with a win for the provider as well, in that their overall costs to manage go down and their overall revenues can even go up. And so, we've got some physicians who are doing the lowest cost of care in the state at the highest patient satisfaction and highest quality in the state, but are also at a situation where they're personally, seeing a revenue stream to themselves, which is roughly double that of a standard primary care physician as part of a NCQA medical home. So I think that kind of brings everything together. And the benefits of that, obviously, the increased patient screenings, tests, vaccines, chronic disease management, patient experience at the doctor's office drives STARS ratings directly in an extraordinarily direct way at a time when the patients are ready to engage. You also get a reduction in unit costs. We've seen significant reductions in ER utilization. We've seen inpatient utilization decreases, and it's a model that's been proven outside of our organization and other organizations as well, with a heavy primary care focus, driven by the kind of actionable data that's really important. And then managing risk for new exchange customers. This is one of those situations where the exchanges are now bringing new patient populations into payers. How are you going to be confident of the fact that those patients are being managed to a plan, managed correctly, and that you're really in touch with the severity of those patients? And so this is a situation where getting them in, getting them evaluated, this kind of thing can be driven by this kind of model, and we've seen it work. In order to do it, however, you really have to, number one, establish that data foundation, get the integration of both the payer and provider data. Off of that, you need to be able to get evidence-based intelligence so you can make the decision. Is this a high-risk patient? And a high-risk patient, those algorithms and those calculations have to be done differently for a provider than they are for a payer. Just going to them, a provider, and saying, based on our predictive analytics, this patient is a 1.6 on ancillary spend for next year, you have lost the provider's cooperation. Whereas if you say to the provider, buddy, this particular patient has, every time you see the patient right afterwards, they wind up with 1 or 2 or even 3 emergency department visits. They see you once a year, but they're seeing 3 emergency department visits, and they're also seeing 3 specialists you weren't aware of. That type of information is extraordinarily poignant to a clinician. They understand exactly what drives that kind of behavior, and they know how to affect it. But you have to be able to get it to them in such a situation that it is driving actionable change in their care plan in the provider's office. And then, who's going to take that information and actually do something different with it? So the practice and care coordination operations have to change. And notably, I think, if anybody on the phone gets one thing from this discussion, it's that the physicians are not necessarily the place to make the change. The physicians have a lot of technology coming at them, a lot of change coming at them. They already have a lot of patients, and they have difficulty navigating multiple different contracts in the course of daily work. It's just difficult. And so, the more of this that can be done by a care team outside of the physician interaction itself, the more likely you are to be successful here. We've driven that model pretty hard. And that really empowers patient change, right? We started the discussion with the fact that, there needs to be a change in the patient, and the patient behavior and the way they seek care and the things that they do around their care in order for us to see a change in outcomes in quality and in costs. Getting to this place where you're changing the patient behavior to leverage that physician relationship, it's really a fair amount to set up for that. The good news is that at the point where you're empowering the patient change, you're seeing a significant win for the payer, significant win for the patient, but you can also be seeing a significant win for the provider as well in these types of partnerships, not just in terms of clinical incentive dollars, but also in terms of the efficiency and the comfort level of the patient, of the practice. I'll give you a couple of examples of that. So Village Health Partners in Texas was the first NCQA medical home, as I understand it, in the state of Texas. It was a standalone regional practice. Now there's 3 physical locations. There's 18 dedicated staff for 30 physicians that are involved in this. And they do about 2,200 inbound calls and 40 outbound calls per day with a 7 a.m. to 7 p.m. support center. So what do they see? They see a significant patient satisfaction increase from actually I don't even think I should tell you what it was beforehand, but nobody who goes to Village Health Partners ever goes anywhere else for their care. And because of that, because those patients are locked in by great satisfaction, they get 100% of their shared savings quality measures met, because when they say, I need you to come in and I need you to do this, the patients do. And so, Texas is, these patients are high quality, they're low cost, and the engagement has been significantly helpful for the practice as well. You look at a Boston Medical situation, significant improvements scheduled and kept, 21% lower no-show rate is just flat out great for the practice's financials. It's great for the efficiency of the practice. But in that situation, they also saw a significant decrease in the overall number of patient admissions. They saw a significant decrease in the number of patients heading to the emergency department, because a significant number of that 20% of patients that were going to the office were avoiding emergency department visits. So we saw we got outcomes to prove a really significant decrease in costs, with a really focus on driving the primary care customer service advantage. And the interesting thing about that is that this kind of stuff is not dramatically new, groundbreaking, genius level stuff. This is focusing very much the same way that an Amazon or a Groupon or a Best Buy, any large consumer-facing organization would do exactly these types of activities to drive patient satisfaction. But in our case, driving the patient satisfaction is really important. Combining it with the evidence-based care at the point of care is what then gets you to the outcomes and quality. I think if we were to talk about this as the top 5 for payers, preserving the patient-physician relationship, not stepping in the way of that relationship, actively trying to improve on that physician relationship is not bad for the payers in any way. And partnering with the providers, because they have that relationship and taking advantage of it, is really the crux of this of accountable care contracting. And I think that bringing tools to bear that help with that, bringing data to bear that help with that, and bringing some of the experience that the payers have with their own customer service operations, I think is something that can be really relatively easily and inexpensively done. Provider organizations have not necessarily had to focus on the customer service experience in the past, and it has been, and it's something, in fact, frankly, as an emergency department physician, my financial incentive is to get you better enough so that you go home and come back. But with my emergency department always being full, it's not necessary. I don't have to advertise for my emergency department. People will come in. It's only recently under these types of contracts that involve attribution, et cetera, that they've had to focus on the customer service relationship financially. And I think that it's becoming something that people are looking to do. So I think as a payer, focusing on that is something that you can be seen as bringing some outside expertise to the table. Bridging the credibility gap between payer and provider. Right now, most of the payer analytics companies are trying to reflect quality data that includes things that are not easily aggregated. And I think the flu shot is the classic example. A lot of people get their flu shots at work, and so that's not easy for me to aggregate. And so when I reflect back to the doctor, here's what I believe your clinical quality is on something like that, the physicians in particular see that as being not necessarily accurate. And it doesn't take much inaccuracy to wind up being to really make it a relationship, to strain a relationship with the physicians. And so getting to a point where you're using some of the customer service interactions to get to patient-reported data around what they've had done and how they interact with. I think that has been something we've seen as a big step and seen as being very a forward way to look at and an engaging way to look at quality. And then data analytics need to be both useful and actionable. So we've seen a lot of analytics. There are dozens and dozens of analytics companies out there in the marketplace. But the analytics are only as good as the data itself, and the data, in particular if you're trying to drive action on it, needs to be recent. And an awful lot of that means driven off of the provider workflow. And so if you're not prepared to get to that point, then getting to actionable data around patients who are driving acute care costs is going to be difficult, if not impossible to do. However, as a part of these contracts, there are more and more companies out there that are able to do that type of work to get that visible and get it into the, and I think that the provider data sets, because they are broader, have critical value to this. And so, the more the payer organizations are willing to participate in good faith and bring the data to the table in an organized way, I think it just really helps bridge that payer-provider gap, and it's seen as being extraordinarily useful. Technology and clinical transformation can build healthier practices. Bringing the technology to the table not as something that's going to bother them by producing another registry which a practice has to deal with, but bringing clinical transformation to the table as something that that you're helping the provider drive better satisfaction, that you're helping to drive significant better compliance. Is something that benefits absolutely everybody, and the practices can thank you for it. And then the clinical integration model, which is currently out there, and certainly Advocate has been a big piece of that. Clinical integration is an important part of the future of healthcare. However, clinical integration is currently, I think, being seen as take a bunch of hospitals and put them together, and then, buy a bunch of practices and put them together with the hospital into one large governed unit, and then put a set of clinical incentive dollars in front of those clinicians in order to change behavior. You're talking about a multi-year, multi-million-dollar effort with significant capital at risk, and unclear return on investment for all the stakeholders. Some people have done it well and gotten great results. Some people have done it not so well and gotten not such great results. But for sure, it's a very large effort. On the other hand, if you basically take some technology tools and put it into the individual practices to buff to the customer service experience around the clinicians without involving the clinicians, other than to see them get benefits from the increased productivity and benefit from the increased information at their fingertips, you can be directly useful to those practices in an extraordinarily short period of time, and be directly managing the cost and the quality of those patients in cooperation with the providers, without all of, as a sort of an adjunct to the overall larger clinical integration experience. And so as I see it, and our organization has really been able to prove this model a number of times, that, focusing on the customer experience, focusing on access, and then using every customer service opportunity to drive a clinical outcome is something that benefits the providers, the payers, and very quickly providers see the model as being a very healthy one for their practices, as well as being a very healthy one for their bottom line and for their relationship with the patients. So in summary, preparing for changes in the reimbursement model can actually produce new revenue and create a preferred branded regional delivery system, which can include the payer and the provider in combination and be extraordinarily effective. Physician workload can actually decrease and satisfaction increase if this is done the right way, which means better engagement. It means you don't have to do some of the really extensive clinical integration work on faith. And our organization's been a partner in helping build some of these practices. And I think there are other organizations out there who certainly have done similar work. But what we're seeing is that the best outcomes we've seen in terms of financials and clinical and financial change has been in combination with a payer and a provider who are willing to think about a future in which they are helping each other, and both sides are benefiting, and in the long run, the patient is the winner, which I think is the thing that all of us should be able to get behind. And I think at that point, I've ended just a few minutes before I thought I would, which I think is useful. If there are questions, I'm happy to take them at this time.
Well, thank you, Dr. Crockett. As a reminder to our participants, to ask a question via the web presentation, please choose the chat pod located in the lower left corner of your screen. Type your question and hit the Send button.
Dr. Crockett, it looks like we have a question that's come in. The question is, I see that you're getting results at the practice level. How is RiseHealth working with payers today? What are you doing for them, and how does that working relation function?
Gotcha. Yeah, fantastic. So, one of the things that we're working with a couple of organizations. One of them is a large Blue Cross Blue Shield plan that is one of the state plans. For that organization has stepped out in combination with a series of practices. So they have contracts that are basically patient-centered medical home accountable care practice contracts with a pretty good number of large physician practices in their state. In order to do that, they've made the commitment to those practices that they're going to provide them with near real-time actionable information and performance measurements, but also tools that help with care coordination. So we are aggregating all of the payer data from the Blue Cross Blue Shield plan. We're combining that with provider data from the organizations that are partnering, and we are creating we have a set of analytics tools that lets a practice see how they are doing in terms of cost and quality, but also is able to in real time drive the actual patient engagement and these types of patient customer service interactions with the patient. So we have a tool that does that. We're working with 2 large Blue Cross Blue Shield plans on that right now. We're also working with a number of smaller payers as well to do this type of work. So all in all, I think there's about 7 million patients that are currently in our database that do that, that see that kind of work. So it's a good size group. It is, and I think that some of the key aspects of that from the payer's perspective is that because we know what we're doing around providers and because we're good at working in the provider environment, the insights that we're calculating for the providers are ones that the payers need to be able to communicate with the provider. And also this concept of being able to do a little bit of to be able to create actionable data in a timely fashion from a message coming in from an electronic medical record, for example, put that in context with all the plan information. That's sort of a new skill set, and we bring that to the table for them as well.
And as a follow-up, how long to launch a program with RISE on the payer level, and also to kind of get it up and running in a provider environment? Kind of a 2-part question.
Sure. Okay. So I think that, again, a number of analytics organizations out there that can provide the sort of analysis that can get you to more visibility or insight around performance and payments and registries. Typically getting the information in, and the problem, of course, with that is that just describes the problem in more detail, and then leaves you in the position where you're producing for the providers in particular a registry of acute or sick or high-risk patients, and then asking them to do something differently around it. So then you look at the cost and time associated of implementing something on the provider side, and all of the variability around all the contracted practices in terms of their ability to build and scale, et cetera. So, if you think about that kind of timeline, RISE is from the time that we, get data in the door to the time that we're able to provide those kinds of actionable kinds of insights. You're usually talking about 3 to 4 months to get the insight, and then you're actually at the same time can be able to manage the patients differently. And so you're getting to the benevolent cycle of analyze, manage, and then analyze your management and make sure you're doing it well. And so I think that combination of things, you're probably looking at somewhere in the 3 to 4 months to get started on that, which I think is there may be other organizations that can do that type of work for you as well. But our organization, is quite good, in particular because we have a bunch of EMR people in the back end. That's been a particular strength of ours, is understanding and getting to the EMR data that you have to bring to the table.
Yes, we've got another question. This one is, when articulating benefits you bring to practices, what role have forecasted changes in provider finances played in defining the value proposition?
Oh, yeah, that's a great point. And then the question is, what are you willing to commit to? So, if you're saying to the practice, I'm going to give you a contract, and this is what your possible upside is, there's a lot of question around a lot of practices in terms of can they make the change, which is why the upside only contracts and the no downside risk contracts, et cetera. And so that becomes a really important part of the conversation. I'm sure everybody on the phone is very comfortable with those types of conversations. In terms of the technology tool, now you're actually into workflow. And so when you're into workflow, you really got to be able to say, hey, this is something that is going to benefit you rather than tax you in terms of productivity. And frankly, some of the meaningful use in electronic medical records work that's been done in the practices hasn't exactly been reassuring in terms of its impact on the practices, either financially or in terms of efficiency. And so I think that, being able to say, based on your information, that there is significant, at-risk, income to be had. That's something that's very clear. I mean, they wouldn't be interested in a proposal if the contract wasn't there, probably. But then by being able to say, we're going to help you grab those dollars by, potentially either referring or putting a product in place that can help you with that, then it becomes a very quick question to say, how is that going to impact us on the financial side? And so having, strong ROI numbers around it, having some experience around that is going to be a really important part of the conversation. Now, luckily, the organizations should be able to provide that fairly easily for you, but you shouldn't go into that conversation around a workflow tool unless you have strong ROI and experience to say that it's going to be a help rather than a hinder. I think that's a great point.
Yes, we've got another question. You've mentioned talking about providers that are managing multiple contracts and are in between fee-for-service and at-risk contracting. How can providers or payers help to move practices to risk contracts? What would be a strategy to facilitate that movement?
Well, I think there's some really interesting work going on around that. First of all, in a physician's office, patients don't walk in the door with a mark on their forehead that says, I'm a Blue Cross Blue Shield alternative cost and quality contract patient, right? Or I'm a TCO contract patient, or I'm an ACO patient. They don't walk in self-identified there. And the EMRs that are in use don't necessarily help very much in that respect. Some of them clearly identify that, some of them don't. Some of them can be programmed to identify that. So some concept of I'm going to help you understand that this is that you're about to see this patient, give them visibility into what the rules are on a patient-to-patient visit. That becomes a really important part of it. So that's number one, is providing them with the visibility on that. Number two, given again the credibility from having providing performance analytics that are credible, that are actionable. I think that that's really important because, again, you're trying to say, take this contract and then we're going to try to help you make it successful. So I think that's an important piece. Obviously, if you are providing, if there is downside risk associated with it, that's a harder pitch to make, and you're not going to be able to do that. And it'll really need additional help. But in terms of how to get people to accept the contract, number one, you got to make the data available and visible so they understand what the rules are and they understand how you're measuring that performance. And then, number two, providing a tool or tools that will help them, get visibility and manage better is going to help you get more contracts associated with that type of thing because, otherwise you're leaving it to the variability of the various practices and their own operations to be able to manage those patients differently and get those patients engaged differently. And some people will be able to do it very well. Some people won't be able to do it very well. And some of them will just not know if they can do it very well. And of course, they're going to have trouble stepping in if they're uncertain of their ability to be successful there.
And I think we've got one last question, and it is, as a physician, how do you get physicians on board? It's clear that there has been some pushback in regard to systems, but in terms of practice transformation, what is the key to getting physicians on board and really partnering with them specifically?
Well, I think it's funny because I heard I've heard that question before in a number of forums. And I typically hear the answer is money, and I can't disagree more strongly. I think that physicians in particular are interested in patient care. They're interested in their own lifestyle. It's an extremely stressful job. They're interested in risk. They're sensitive to risk because the malpractice risk associated with some of the things, the activities that are necessary to do population health. When you have to have a hard conversation with a patient about a resource that you don't think that they need or a surgery that you don't think that they need, you better have the evidence to back it up. And so, I think that there's a lot going on in the physician world, and if you are able to provide a roadmap to a better, more successful practice and lifestyle, that is really going to have a significant draw. Now, if you are a large integrated delivery system that wants to buy a practice, and you're going to be in the workflow and providing services, it's easy to make promises that are going to be really, impactful for the providers. That's not necessarily going to help you as a payer. But I think that if you're able to say, look, we have a call center. We'll help you by taking some of your workload and bringing that to us. So help us help you with our tools and our engagement and do it on your behalf. That is a direct help to the provider. When you say we're going to structure this contract based on information that we know we can get and we can help you get. And then we'll look at it in a series of exercises that are transparent, and you'll be able to see the same tool we see. That is going to help you with that relationship, and that's going to help. That's going to be seen as an assistance for the patients. Just putting a new contract in place and then saying we're going to drop a registry, every 3 months or something that says, hey, pay attention to these patients, is just not, it's more of the same. It's not going to get you there in terms of engaging the physicians differently and leveraging that relationship between patient and provider. If that's what you're after, it requires a more of a commitment and a tighter relationship with the providers. And it's just, and I think that being willing to step forward with your data and your technology associated with this is something that we've seen it work very well, and also some flexibility. I mean, one of our practices went to the provider and said, look, we're using this software that lets us do evidence-based clinical support over the telephone, and we want to, and we're doing it with MAs because we don't think that we need RNs to do this. The chief medical officer of the plan met with the practice, went in, sat in the practice, watched the use of the tool, really got into the depth of it, and found that the MAs were doing every bit as good a job of care coordination driven by technology as an RN level person would be willing to do or was able to do, and so they were willing to allow that practice to continue that under that contract. And that was a significant benefit financially to the practice, and the patients were getting better service than ever. And so I think it's that flexibility with the providers. If there's good ideas and good innovation coming out of the providers that the payers can participate in as well, I think that kind of partnership and that stepping in good faith is a really good way to get the providers to into new contracts and to partner and really help them. It's a long answer to a short question.
Well, I believe that concludes all the questions that we had today.
Well, thank you guys very much for your time and attention. Appreciate it.
And thank you, Dr. Crockett, for that great presentation and for sharing your thoughts today. Thank you to the audience for participating in today's conference. That concludes this webinar. Thank you again, and enjoy the rest of your day.